I will be talking about the non-motor symptoms of Parkinson's disease, and this is a topic that literally has entire books written about it, and we have 20 minutes. So I have a lot of information on my slides, and I'm not going to just read it to you. You have the slides in front of you, so some of the nitty-gritty details you can maybe look back on if you have any things that sort of stick in your mind or that you want to come back to later, maybe with your doctor. So a broad overview of the things that we'll be talking about is shown here. We'll be talking about autonomic symptoms, and I'll talk a little bit more about what that means, as well as sleep symptoms and mood and cognitive symptoms. So as we start, we'll start with a quote, which is that it's tough to make predictions, especially about the future. And this is a quote from the late, great Yogi Berra, who was famous for such quotes. And what I mean in this context is that don't think of this presentation or these slides as a checklist of things that are coming down the pike for you. Not everyone will have all symptoms, and not all symptoms need to be treated. So the purpose of this talk is really to raise awareness. And if you see something that you think, oh, I have that, and I have never talked with my doctor about that, or my spouse has that, and oh, we didn't realize that it might be a part of Parkinson's disease, that's really the purpose of this, is to identify the areas of non-motor symptoms that are amenable to treatment, because treating them can often improve quality of life. So when we talk about autonomic symptoms, this refers to gastrointestinal, urinary, and blood pressure symptoms. The autonomic nervous system, think of it as the part of the body that is in control of automatic functions, things that you don't have voluntary control over. So that would include things such as digestion and blood pressure. So the first topic that we'll discuss is constipation in Parkinson's disease. And one of the reasons that we start with that is because it is nearly universal among people with Parkinson's. So we'll talk about treatments in sort of an order of ascending intensity. And so the non-pharmacological treatment options, some of those are listed here. Getting better hydration, exercising regularly, increasing fiber intake are all things that can be helpful. One of the tricks that I have learned is, that sugar-free gum, which can be useful if you have dry mouth. Sugar-free is because it has sugar alcohols in it, and sugar alcohols like sorbitol can also be helpful with constipation. So these are some of the little pearls that I'll try to point out. So there are a number of over-the-counter treatments that can be helpful, and these are listed here. I tell people to start with a stool softener, which is docosate or Colace, anywhere from 1 pill a day up to several pills a day. Laxatives can also be helpful, but have the potential to be habit-forming or to make the gut get lazy over time. So at the beginning, I tell people not to take those on any more often than an as-needed basis. There are also a couple of prescription medications that can be helpful. Pyridostigmine, I'll mention in a couple of slides again. And then one of the strongest medications that we have available is known as imidazole or lubiprostone, which is approved for idiopathic constipation, but can be helpful for severe constipation in people with PD. So drooling is a symptom that can be very bothersome, especially in some of the moderate or more late stages of the disease. And what happens is that in Parkinson's, a lot of the automatic movements occur less often or are smaller, and this includes swallowing. So the salivary glands aren't actually producing more saliva. People are just swallowing it less often. And you combine that with a forward head position that many people have, and then it creates a problem with drooling. So the treatment is either to increase spontaneous swallowing or to decrease saliva production. And keeping something in your mouth, sugar-free gum, sugar-free candy, can help to trigger more frequent swallowing reflexes. And then although extra saliva isn't the problem, reducing saliva can be helpful. And that can be either pills with medicines like Robenal, which is glycopyrrolate. Sometimes we borrow a medicine from our eye doctor colleagues, atropine eye drops, and can actually put those under the tongue and dry the mouth out for a few hours. Or the last treatment listed there is one that many people find helpful, which is actually injections of Botox into the parotid glands and the submandibular glands to decrease drooling for as long as 3 months per treatment. So another autonomic symptom to talk about are urinary symptoms. And the most common symptom that some people with Parkinson's experience is an overactive bladder. So this is having to urinate more frequently or with some urgency. And there's a number of medications listed here. There are several so-called anticholinergic medicines, which have been around for a long time and are generally the first line of prescription medicine treatment. And then the newest kid on the block is listed at the bottom, which is mirabegron or mirbetriq, which works via a different mechanism, a beta-3 receptor rather than an anticholinergic effect. But the effect is the same, which is to relax the bladder muscle and decrease that sensation of overactive bladder, which can really lead to an improvement in a person's quality of life if that symptom can be brought under better control. So this is a big mouthful of words here, neurogenic orthostatic hypotension, which basically means dizziness. So if a person gets up out of bed or gets up out of a chair and feels lightheaded or even passes out or feels mentally fuzzy or feels tired, that's often because the blood vessels in the body are not tightening up like they should when a person is upright. And this can cause a drop in blood pressure, which can cause all of those symptoms that I mentioned. So the treatment for this, the first thing is to reassess whether a person who is on high blood pressure medicines actually still needs those. A lot of times in Parkinson's, some of the medicines that we use for other things like high blood pressure can actually be peeled away, and that's the right treatment rather than adding another pill into the mix. There are then some non-pharmacological options that can be helpful, simple things like standing up slowly, elevating the head of the bed. This is actually putting the head of the bed on bricks or blocks to elevate it by about 10 inches, which if you don't slide down towards the bottom of the bed can be helpful. Increasing fluid and salt intake, frequent small meals, and compression stockings can all be helpful. And here we see the world's easiest to put on compression stockings requiring just one person and just a couple of fingers worth of pressure. And people that have tried to put compression stockings on are laughing because it can be challenging, but it can be quite helpful. There are a number of prescription medications that can also be helpful for NOH, neurogenic orthostatic hypotension. And some of these have been around for decades and include medicines that we usually refer to as Florinef and Midodrine. Florinef helps the body hold on to more salt and fluid, so we can think of that as filling the tank. And Midodrine is a blood vessel constrictor, so it helps to squeeze the tank. There's also a relatively new medication that's been available for about 1 year. And the same way that one of our main Parkinson's medicines, Sinemet, is a dopamine precursor that the body turns into dopamine, this medicine is a norepinephrine precursor, which the body turns into norepinephrine, which is a different chemical pathway that also tends to be a problem in Parkinson's disease. There are a couple of other medicines here that are two birds with one stone. And so I had already mentioned pyridostigmine, which can be helpful for constipation. It is one of our third-line medicines for low blood pressure or dizziness. And then a medicine available from compounding pharmacies called domperidone can also be useful for nausea as well as lightheadedness. So let's talk about sleep symptoms, because all of the other medicines, all of the other treatments that we have can feel like you're spitting in the wind if you're getting a terrible night's sleep on a consistent basis, and sleep is often a problem for people with Parkinson's. And so insomnia. The type of insomnia that most people with Parkinson's can experience is in the middle of the night. They're able to fall asleep okay at whatever the regular bedtime is, but come 2 a.m., it feels like it's time to wake up, and it's hard to fall back asleep. And this can be compounded by overactive bladder, if that's also a problem. And so there are a number of treatments that can be helpful for this. What I usually tell people to start with is over-the-counter melatonin. This is available without a prescription. Melatonin is the body's natural sleeping hormone, and people with Parkinson's tend to run low on that. And so melatonin, in some cases, can be extremely helpful for helping people fall asleep and stay asleep. There are then a number of prescription medicines, clonazepam. I'll mention this medicine several times in the sleep section because it can help with insomnia as well as some of the other sleep issues that can come up that we'll talk about. There are then also some antidepressant medicines with the names of trazodone or Remeron that have a sedating aspect to them. So this is another one of those two birds with one stone area. If a person is battling depression and also insomnia, those medicines may be a good option. A note of caution is that I usually tell people to avoid Benadryl or Tylenol PM, which is just Tylenol with Benadryl, or Advil PM, which is Advil with Benadryl. This chemical, diphenhydramine, is helpful for allergies. It can be helpful for sleep, but it's an anticholinergic medicine, and that can sometimes cause confusion, especially in later stages of Parkinson's. So I generally tell people to not go that route, the PM medicine route. So this is what is known as sleep hygiene, which doesn't mean taking a shower or a bath before bedtime. It means doing behaviors that increase your chance of getting a good night's sleep. And in the interest of time, I'll let you look over this independently, but I consider each of these things to also be important beyond medicines. So the other side of insomnia is excessive daytime sleepiness. Certainly if a person's not sleeping well at night, that will tend to cause them to be sleepier during the day, but people can also be sleepy during the day even if they are sleeping well at night. So address insomnia if it's present. It's fine to take naps. I would rather a person take a nap than another medicine if a nap works. Then there are pharmacological treatments. One of the considerations is to adjust the dose of Parkinson's medicines, particularly the so-called dopamine agonists, which is Mirapex and Requip. Those medicines are more likely to cause sleepiness than most of the other Parkinson's medicines are. So sometimes we think about using less of that and more of something else if sleepiness is a big problem. Caffeine can be helpful, and then there are a number of stimulant medications which are off-label for sleepiness in Parkinson's, which sometimes creates a battle with the insurance company, but can sometimes be helpful in addition to the other measures listed there. So restless legs, this affects about 10% of the general population and a little bit more of the Parkinson's population. This is a creepy, crawly feeling inside the legs that tends to be worse in the evenings, especially at bedtime, and makes a person feel like they need to march or get up and move or shake their legs out. And fortunately, people that are on medicines for Parkinson's often find that their restless legs also improves because the set of medicines that we use for each overlaps almost completely. There are also a number of other medications, including gabapentin, clonazepam, and in some severe cases, even narcotic medications. Related to restless legs is periodic leg movements. This is not so much the creepy crawly feeling, but an actual jerking movement that can happen either during drowsiness or when a person is actually asleep. And this can be disruptive to a person's sleep without them even realizing it, or even more disruptive to the bed partner's sleep if the legs are jerking every 30 seconds all night long. And so the medicines that can be helpful for this are melatonin and clonazepam, as well as some of the ones on the previous slide. REM sleep behavior disorder is jumpy legs on steroids. It can be any part of the body. It can be vocal, sort of yelling out or talking in the sleep, or actually punching and kicking, or as severe as getting out of bed and running across the room while a person is still asleep. We're supposed to be paralyzed when we're asleep, and people that have REM sleep behavior disorder are not. And so sometimes it's necessary to use protective measures like moving sharp things away, even using bed rails or a barrier between the bed partners, sometimes even sleeping apart. But this is fortunately something that usually responds well to treatment, either with melatonin or with clonazepam. And so if this is a problem, it tends to be fairly low-hanging fruit in terms of something that we can make better. So the last area that I'll talk about are mood and cognitive symptoms. Depression is very common in Parkinson's disease and often under-recognized because some of the same things that are just symptoms of Parkinson's, a decrease in facial expression, slower movement, those can be symptoms either of Parkinson's or of depression. When we talk about treatment of depression, the dopamine agonists, again, this is Requip and Mirapex, they have evidence of their own that they can be helpful for depression, probably more so than Sinemet is. And so if a person is just being diagnosed with Parkinson's and has significant depression, this is sometimes a reason that I'll start with the dopamine agonist rather than Sinemet or some of the other choices. There are also a lot of prescription medicines out there that can help depression in anyone, including people with Parkinson's disease. Anxiety highly overlaps with depression and can sometimes be even more problematic, and the treatments for anxiety are generally the same medicines, the same talk therapy, the same dopamine agonists can be helpful for anxiety as well as for depression. I mentioned clonazepam here again as that medicine that can be helpful for sleep and REM sleep behavior disorder, but we do use it with caution if it's just an issue of anxiety because of the sleepiness that it can cause and sometimes balance difficulties. So cognitive changes in Parkinson's disease is a big topic, and this is one of the aspects besides the tremor and the slowness that people are most worried about, even from early stages of Parkinson's disease. And what people might notice is a slower mental processing or difficulty with word finding, more of the tip of the tongue phenomenon, just not quite being able to find that word. So dementia is a big, scary word, but we define it just based on symptoms. If a person is having thinking and memory problems that are severe enough that it's affecting a person's ability to do their everyday activities, driving or cooking or other things that they want to do in their day-to-day life, if it has risen to that severity, then we will often use this word, dementia. Some other symptoms that can happen often late in the course of the disease are hallucinations or agitation. And so there are a number of medicines that can sometimes be helpful. Probably the most important thing is to reduce medicines that can be sedating. There are a number of prescription medicines that can be helpful, including potentially a new medicine in the next few months called pimavanserin, which works on a totally new chemical pathway. So this is potentially going to be a new treatment option that will be available to us soon. If there are nighttime or daytime hallucinations or agitation, then medicines with the names of Seroquel and Clozaril can be helpful. And then the other so-called antipsychotic medicines should be avoided because they can worsen the physical symptoms of Parkinson's. So I think this is my last slide, and it is sort of an overview of what is helpful not just for the thinking and memory symptoms of Parkinson's, but really all the symptoms of Parkinson's, from constipation to depression. Remaining physically active and mentally active is one of the best medicines, both for the physical motor symptoms of Parkinson's and for the non-motor symptoms. And so staying mentally active, whether that's with puzzles if a person likes to do that, or even just staying socially engaged and having a weekly or a daily coffee meeting with friends, these are all things that are medicine for the brain. And so I think that it's most important to find both physical and mental activities that are enjoyable so that they can be sustained over time. And so with that, I think we have some time for questions, so thank you all for your attention. So we'll maybe start in the front and work our way back.
I have sleep apnea and great full mass. How does that interact with all the stuff that's going on with Parkinson's, and I have very bad spine?
So the question is about sleep apnea and how does that interact with the other sleep difficulties. Sleep apnea is also common in people with Parkinson's disease and needs to be treated with the mask, CPAP or BiPAP, above and beyond everything that's listed here. And so that's certainly an issue that we look for and address separately.
Because, and this is about kind of mild cognitive impairment over to dementia and that whole line. And the reason I'm asking is because there could be, as you said, medication that can slow it down or address it. So can you go a little bit further into that gray area of when it's a little bit of cognitive impairment versus dementia, and other than the main ADLs, kind of what the clues are, and then also does an MRI or anything, a scan, show any evidence to delineate that?
Okay, so the question is about the spectrum of cognitive impairment from normal cognition to mild cognitive impairment to dementia, and also whether an MRI might be helpful. And so it is really a spectrum, and it's basically defined functionally. So if a person comes in and they say, boy, it takes me a little longer to figure out how to use the remote, and it took me 30 seconds to remember my friend's name the other day. If it's not affecting driving and cooking or causing accidents, then we often use the term mild cognitive impairment. And I will sometimes refer my patients to our neuropsychological colleagues who can do 4 or more hours of thinking and memory tests, sort of like when a high school student takes the SATs, to really pin down areas of strength and weakness and identify, is this more of a mild cognitive impairment or dementia? An MRI I find to generally be unhelpful in making this distinction. An MRI can look bad while a person looks pretty good, or vice versa. And so it's really more a matter of talking with a person and talking with the care partner and seeing how things are going on a day-to-day basis that's more useful.
Can you talk a little bit about numbness of the extremities?
The question is, what about numbness in Parkinson's disease? And there are certainly some non-motor topics that didn't even make it into my rushed through slide set here. But numbness is actually pretty common in people with Parkinson's disease. We use the term neuropathy, which means nerve problem. And neuropathy is more common in people with Parkinson's than in the general population. And this can feel like a coldness in the feet, or numbness and tingling, or just a lack of sensation in the feet. If it's painful, there are medicines that can help with it. If it's just a lack of sensation, then it's unfortunately something that we don't have a specific treatment for. And it's just something for us to be aware of and work around.
Yes, my wife, she had a stroke and she also has Parkinson's. When she's tired, she kind of mumbles, and I can't tell if it's from the stroke or from the Parkinson's.
So the question is about someone who's had Parkinson's and has also had a stroke and then has soft, mumbly speech when they're tired. And hard to tell the difference for the husband between the two. Hard for me to tell the difference between the two, because it can certainly be either. And a softer voice, hypofonia, is very common in Parkinson's disease. And I would say that if this seems to be something that's more associated with fatigue, and it's a softness rather than a slurring, that it's a little bit more likely that it's the Parkinson's rather than the stroke, but it certainly could be some of each.
Melatonin you talked about is used in several different issues. Is there a starting dose of melatonin? Is it dosed by kilograms, or is it just tablets?
So the question is about melatonin, helpful for so many things. What's the dose? I usually tell people to start with 3 milligrams, but the dose range is pretty large. Some people feel zonked on 3 milligrams, so I tell them to lower it. If people say 3 milligrams doesn't do anything, I'll have them take 5, 6, even 9 or 10 milligrams. And so it's a gradual adjustment process.
Is there any downside to long-term use of melatonin?
Is there any downside to long-term use of melatonin? It slightly, even in the short term, increases bruising risk. It has a slight blood thinning quality to it, but there are otherwise no negative long-term side effects in my mind.
So it doesn't
Does it affect memory? Any medicine that is sedating has the potential to affect memory in the short term, but I don't think of melatonin as worsening memory or thinking in the long term. I'm going to keep working towards the back because you've had your hand up the whole time.
I've only recently started to hear that some of the non-motor symptoms of apathy, anxiety, and that may be also related to psychosis, which brings that sorting out cognitive psychosis. Can you address anything about psychosis and Parkinson's?
So psychosis in Parkinson's disease is a not uncommon symptom, especially later in the course of the disease. And it's a complicated issue that seems to have to do with both the dopamine pathways as well as maybe the serotonin pathways, which is why this new medicine is actually a serotonin medicine trying to accomplish the same thing in a different way. And so in terms of what causes psychosis in Parkinson's disease, I think of it as sort of part of the package that can occur with more severe cognitive changes, sort of from a difficulty with separating the real world from sort of other things that are less real. So my answer, I don't know if I'm getting at your question sort of in a roundabout way. Okay.
My mom lost her sense of smell about 30 years ago. She's having problems remembering how to breathe through her nose. She's breathing through her mouth. And when we ask her, we can't hold something up for her to sniff because she doesn't smell it. So what can we do to try to help her consciously breathe through her nose?
So the question is about loss of sense of smell and mouth breathing versus breathing through the nose. Loss of sense of smell is extremely common in people with Parkinson's, which can also affect sense of taste. And it often happens decades before a tremor or any physical symptoms of Parkinson's disease. So there's not a specific treatment to help regain a person's sense of smell.
I'm talking the nose breathing. How do we reteach her how to breathe through her nose?
It's a good question. I don't know that may be an uphill battle because people tend to develop a breathing pattern, and I don't know if there's any way other than constant reminders that breathing through the nose is.
She said she doesn't know how. That's what I'm saying. Is there anything to cue to remember other than just stretching her?
Sure. I would say working with a speech therapist might be helpful. Yeah, okay. So I think we have time for maybe two more. One more? And I'll be available afterwards also.
I have a lot of problems with sleep disorders, and I have a lot of nightmares. Does that have anything to do with the time that I take my Cinnamon at night, or taking it too late? Would that affect it?
The question is about sleep and specifically nightmares, and is it partly Cinemet's fault? The answer is it could partly be the medicine. The dopamine that Cinemet is turned into can sort of increase vivid dreams. And so it's a rock and a hard place because Cinemet at bedtime can often make it easier to get comfortable in bed, but Cinemet at bedtime can sometimes increase vivid dreams. So that is
I've been told I'm very vocal at night.
very vocal at night. So the vocal at night, that's probably an aspect of the RBD, the REM sleep behavior disorder. And so trying the melatonin or the clonazepam potentially could be helpful. So we're going to move on to talking about nutrition in Parkinson's disease. Thank you all for your attention.